All right. So again, I'm Matt Allemang. I'm local. Thank you for allowing me to speak on this topic. We're talking about scoping in the ICU and some of the things involved. I have no disclosures. So the main reason I'm usually going to the ICU is for feeding tube placement, but our GI colleagues go there pretty frequently for GI bleeding, ruling out ischemia, other things. But as you may know, if you've scoped there before, it's quite a limited place to be. You need to remember that you don't have all your resources. You're sometimes far removed from the endo suite or the OR where all of your extra implements are being held. So bringing whatever you can as you come. Space is sometimes a premium. You're sometimes limited to the number of endoscopy RNs that'll come and help you out. So if it's just one and they're bringing the cart, it's just you, it's a little bit tougher. And sometimes there's availability for help with sedation depending on your local environment. So basic travel carts, they come in multiple sizes. The behemoth on the left is one that has to have an actual motor to kind of push it around the hospital. There's also the slim and trim high tower that we have that you could actually fit an electric cautery. But some of the elements, the light device, the processor, irrigation, all these are kind of basic things that you see on any travel cart that you're going to be using. The importance of an extra supply cart cannot be overstated. And having these pre-stocked with a lot of things that you're going to use in the ICU are important. You can even allow to have a wireless secondary monitor to kind of help when you're in a tight spot at a weird angle, just to get better visualization of whatever you're dealing with. List of things to not remember or not forget as you're getting there. So if you're going there for bleeding, make sure you bring your electric cautery, your APCs. If you have pre-set up a bleeding box or a cart, bring that with you. Clips, injector needles, banding kits, coag forceps, a lot of things Dr. Fatzler showed us. Roth nets, snares, balloon dilators. If you're doing a double, so an upper and a lower, you bring 2 scopes. If you think you might get into some type of stenosis, you need to bring an XP scope. Just things to consider ahead of time. Again, we talked about the second monitor, and very infrequently you need to bring a CO2 insufflator. Again, a little bit later. So average ICU room, it seems like you have a fair amount of room, and the only problem with this particular one is that we have the windows open, and it's hard to get a good view sometimes unless you can really get the shades down. The advocacy is to scope at night, I guess. So the ideal ICU setup, you've got your electric cautery and your travel cart straight across from your endoscopists. You got a couple RN endo nurses in there. You got plenty of room for all of your supplies, plenty of room for your ventilators and pressors and all the things that you typically see in the ICU. But we all know that's not the typical ICU patient that's getting scoped. So it's usually much more cramped. You can only have room for a couple of people. Your supplies are on a chair instead of a table because that's all you fit in there. But bringing that extra cart, having it outside the room with all your extra supplies is paramount. A little bit about ergonomics. So endoscopic related injuries are pretty prevalent. Hands, neck, back. And just thinking about this, if you're especially in a tight situation, it's minimal things, but kind of adds up over the years. More frequent in folks with that are further along in practice and doing high volumes. So the big things to remember when you're in this tight space in the ICU and there's not a whole lot to go around is put your monitor straight across from you, keep it at eye level. We all know this from our laparoscopic stuff. So. And then your elbow should be between 0 and 10 centimeters from the bed. And just remembering these couple points just to kind of keep yourself safe and scoping well into your practice. The type of sedation is going to be dependent on the patient and what they can tolerate. So some of these patients are already intubated, non-sedation, and they don't need anything additional. And others are kind of tenuous, and should you consider having them intubated before you even go, especially in a massive upper GI bleed? I would advocate, having the patient intubated just to protect their airway so they don't aspirate. And then next, the importance of resuscitation is really paramount. So hemoglobin greater than 7, if they're actively bleeding, do not hesitate to give them blood products while you're scoping. 1-to-1-to-1 ratios, like a trauma scene. So a lot of these things are going to be talked about in the subsequent lectures to follow mine. So I'm just going to focus on the ones that probably aren't going to be covered. So bleeding and colonic decompression. So, urgent upper GI bleeding is something, thankfully, my GI colleagues take care of way more than me. But, the left-hand side there, you see gastric or esophageal varices with a fibrin clot from a recent bleed. The two upper pictures are the banding device before and after band deployment. And just below that is some of the stigmata of impending bleed, the red whale sign in the middle and the cherry red spot. You can get malleolized tears for forceful vomiting, and then, just good old-fashioned cancer can bleed, especially when there are all the DOACs around. So for a couple learning points for non-variously upper GI bleeds, it's really changed since PAPIs have been kind of introduced, and they really serve a huge role in this. We put them on prophylactically, and there's very little downside, so we do it all the time. But something to remember before you scope these folks for upper GI bleeds is to help remove some of the clot burden. So that's with promotility agents like erythromycin or Reglan, given 20 minutes to a couple hours before. It's just going to save you a lot of time and help you find kind of what's bleeding in the first place. Moving on to some of the learning points for just variceal bleeding for those of you that don't do it very often. Blakemore tubes are something I'll get into in just a minute, but there's an indication for IV antibiotics for at least a week around the time for these cirrhotics. Don't forget your IV octreotide. If you do find bleeding varices, urgent endoscopy is indicated, and this is definitely a patient that needs to be intubated prior to doing a scope. So Blakemore tubes, just as a refresher, they're infrequently used, found in the ER and the ICU mostly. It's a nasogastric tube that's put down. First, the gastric balloon is inflated, and then it's put on tension, usually with just a saline bag. And then a lot of times that'll be able to tamponade the varices enough to resuscitate the patient if they're decompensating. If that doesn't quite work, then you can inflate the esophageal balloon. And this is just a really quick, helpful YouTube video. It's like 5 minutes long, just to refresh yourself if you have to do this in a hurry. Kind of goes over all the basics. So banding is obviously superior in controlling bleeding varices. Beta blockers after the fact to help prevent rebleeds by dropping by at least half. These patients usually need more than one scope to control everything. And when you're doing bands for esophageal bleeds, it's important not to stack them on the same level, but to kind of band in a spiral because they tend to stricture down and ulcerate from the bands after the bands fall off. PPIs are something we use to try to prevent the ulcers, although that's not proven. Moving on to the other big thing. So the left-hand picture is a sigmoid volvulus. You guys will hear about that in just a little bit. But acute colonic pseudoobstruction or OGLVs is another reason you might be scoping someone in the ICU. So the algorithm moving down for OGLVs is usually conservative management, and we're all praying for that to happen. But if that doesn't work, they're usually transferred to the ICU for neostigmine, and that's where it really comes down to why they may need a scope here. If the neostigmine doesn't work after the first or second doses, then colonic decompression is indicated at that point. So things to remember when you're doing colonic decompression. This is the role for CO2 if you do have it at your facility and can fit it on the travel card. You want to use minimal insufflation, reach at least the distal transverse colon and suck down into as much of the extra gas as you can. There's a small risk of perforation, a pretty high risk of recurrence, and I'm always amazed by the tiny tubes that are placed in that I don't really think help at all, but everyone likes to feel like the tube helps, so they put it in anyway. So that's really all I have today. The big take-home point here, you're scoping the ICU. If you fail to plan, you plan to fail. Knowing kind of what your facility has to offer, what you foresee you may be getting into is really paramount. So thank you all very much.